We've got a phenomenal day ahead of us. We've already actually, since 7 o'clock this morning, had a fantastic group of more than 100 patients and caregivers come and start to talk about a day of engagement and co-design of the healthcare system focused on quality. And now we're transitioning to the rest of the day. And it is an amazing day. My name is Dr. Joshua Tepper. I'm a family doctor, and I am proudly the president and CEO of Health Quality Ontario. And it gives me a huge amount of joy to once again welcome you to what is, without doubt, Canada's largest conference on healthcare quality. We have grown steadily year over year, and that growth, I think, speaks, and I will talk more about this in just a minute, to the incredible momentum that is growing in the province of Ontario around quality of care. Normally, I start our day with a patient's story. Last year was actually the story of my own child, who'd been born just a few days before HQT. So she just had her first birthday. We now celebrate HQT and her birthday together. They're just one and the same in my household. It's great. I just give her sort of stuff from work that says HQT. She's happy. I think I can get through to like age 12 with HQT material. Nobody tell her differently. But in fact, today we're very lucky not to hear the voice of a patient through me, but actually to start our day in just a few minutes by hearing from David, who will share his own story of the navigation of the healthcare system, his own experiences with the healthcare system. So instead, what I want to talk a little bit about today is what it actually, I think, means to say that we have a room today of 2,500 people who wanted to come to a conference of quality. What does it mean when you have 2,500 people who were lucky enough to sign up in the first 23 days before we had to close registration, and there's been another almost 1,000 who have asked to join since then? And what does it mean when we don't just have those 3,500 people who've raised their hand and said, I want to participate in a conversation about better in the province of Ontario, but we actually know that beyond those 3,500 are hundreds and thousands more? What does it mean when I look out at 2,500 people and I know in my head there's another 1,000 and beyond that thousands more, and they're not just patients, they're not just doctors, they're not just leaders, they're not just from the GTA, they're not just from Northern Ontario, they're not just from hospitals, they're from all parts of the healthcare system. I think what that means is an opportunity. At the risk of dating myself, I remember a movie. It's not Casablanca, I'm not going that far back. I heard it was great, though. There's a movie called Gangs of New York. And Leonardo DiCaprio was one of the guys in there. And at one point, he looks out and he sort of looks at all the people who are sort of like him and sort of have his belief and have his passion. And he says, you know what? If we all get together, we don't have a gang, we've got an army. And when I think about it, now in Canada, it would be a peacekeeping mission. But when I think about 2,500 people and another 1,000 and thousands and thousands more, what I think about is we've got an army who are coming together for one purpose, and that is to make care better. And I think about this conference as a chance, as an opportunity to do something different. So in 1900, there was a famous mathematician, a guy named David Hilbert. And he opened the 1900 International Mathematician Congress by throwing out 23 puzzles, 23 unsolved puzzles. Your friend on the front row is smiling because he solved 7 of them. But they were 23 unsolved math puzzles that as he opened this Congress, he said, who among us would not be happy to lift the veil behind which is hidden the future? Because he saw in these challenges the opportunity to find answers that would transform mathematics for literally centuries to come. More recently, one of our colleagues in healthcare, Peter Singer, has adopted this notion of challenges and grand challenges. And he talks about grand challenges in healthcare, and he talks about grand challenges being a critical barrier that if we could collectively work on it, if we could actually join our efforts, we could fundamentally change healthcare. And so what we've actually been doing at Health Quality Transformation over the last 3 years is picking a grand challenge after a grand challenge after a grand challenge to share with you, not to share with you for the point of sharing, but to begin to jointly work together. So 2 years ago, I stood up here and I talked about a new partnership with CAHO, the Council of Academic Hospitals of Ontario, and a project called Arctic that we had just agreed to work on together, and that project would work on one of the hardest problems that quality care has, which is this issue of spreading and scaling knowledge into frontline practice. And 3 years later, that program goes well. Yesterday, Helen Bevan came and spoke on that very important topic. Last year, Danielle Martin spoke on that very important topic. And organizations, many of whom are in the room, like Cancer Care Ontario and the Ontario College of Family Physicians and AFTO, the Nurse Practitioner Association, all of us are collectively trying to figure out how do we quickly take what we know is the best evidence and the best practice and actually get it out across the province. Last year, we talked about another grand challenge. The grand challenge of actually saying, what is quality? And I stood here with Dr. Staney Brown, and I said, you know, we can't all work together if we don't have a common understanding of what quality is. And so we introduced this concept last year, including a video by Seema, who's here in the front row with us, about the voices of patients saying, what is quality? And we then introduced a placemat that has now been downloaded thousands of times and presented across this province, called the Quality Matters Placemat, which among other things very clearly outlines 6 dimensions of quality. And those are now 6 dimensions which are embedded behind the quality improvement plans that more than 1,400 organizations across the province of Ontario complete every year. It underpins our public reporting, and increasingly organizations have joined the Institute of Medicine to make sure that their quality agenda is doing. And it is a grand challenge to actually come up with a common understanding of what quality means. And so when I say quality and you say quality, we actually mean the same 6 dimensions, and that means when we speak the same language, we can work together. So what is this year's grand challenge? What is this year's opportunity that I'm hoping that the 2,500 here and the 1,000 more who wanted to be here and the thousands more who every day go to work believing in better can lend their voices, their energy, their wisdom, their experience to? And that problem is variation. And we've known about this for a little while, but we haven't talked about it with the sharpness that we should. We haven't talked about it with the crispness, and I think, in fact, the shock that we should. And it is everywhere in our healthcare system. I could literally fill the morning, but I won't. I promise. With examples. But let me give you just a few. And this isn't comparing country to country or one part of Canada to another part of Canada. This is simply looking at Ontario. Just one province under the same regulatory frameworks and funding frameworks and everything else. And let's start with long-term care. And this was a report we put out a couple years ago about the use of antipsychotic medications in those who do not have psychosis. And depending which long-term care home your mother, your father, your family member, your loved one is in, the rate of antipsychotic use is anywhere from about 0 up to almost 60%. Mental health has appropriately taken a lot of our attention recently. They are among our most ill. They are among our most vulnerable in our population here in Ontario. And we know these days you don't get into hospital unless you're particularly unwell. And we know that when you're that sick, that one of the most important ways of having you return to hospital in a short time is rapid follow-up in the days afterwards. And we've known this for a while. And yet what you see on this slide is that follow-up within 7 days of these acutely unwell patients who are incredibly vulnerable, often on many medications, often with limited support. No place in Ontario has crested 60%. And even if we then say, well, that's unfortunate, what we then see is a range of anywhere between about 16% to about 40%. Not quite. Huge variation just across Ontario. And then we take a look at the remarkable and very unfortunate issue of amputations related to diabetes. Diabetes is a hard disease. It is a terrible disease. More and more Ontarians every year are being diagnosed with diabetes. And of the many complications that happen, including blindness and stroke and heart attacks and kidney failure, are amputations. And what you see across Ontario again is dramatic, multifold variation in the rate of amputation. And we can look at this and we can sort of think about it, and we know why some of this is happening. We understand why. We can say, whoa, 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 we know why this is happening. That's great, but knowing why is not acceptable. We actually have to start to solve it. It's not enough to say, in this case, we know why it's happening. We actually have to say, we know why it's happening, and now we have to reduce this remarkable rate of multifold variation leading to amputation. We talk a lot about hysterectomy rates, and again, from one part of the province to another, you see a 10-fold variation. And when you actually calculate how many fewer operations each year that women would have to have, if the provincial average was to drop to the lowest, it's almost 7,000 fewer hysterectomies each year, with the associated cost, delay of other services and access to other services, and of course the morbidity and rarely, but still potentially mortality that comes with these operations. Opiate prescribing is something that's been in the news these days a lot. And yet, county by county by county across the province of Ontario, you see a 10-fold variation. Again, a 10-fold variation, county by county, across the province of Ontario. So what do we do about it? That's our grand challenge. That's our why. That's our grand challenge. 10-fold variation for common procedures like hysterectomy, for commonly prescribed drugs like opioids and antipsychotics, and devastating diseases like and activities like amputation. So that's our challenge. That is our grand challenge. So what do we do about it? We want to talk today about a new program that HQO is launching called our Quality Standards Program. We're not the first in the world to take this on. The UK has done this for a long time. Australia has been doing it for a long time. But we think Ontario has a chance to do it better, differently and better than any other jurisdiction has done it before. Each standard that we produce is not just going to be a standard, a piece of paper alone. It's going to be a program. It's going to come out with a set of organizational tools to actually change the delivery of care systematically, starting with the minister's office down to the front lines of care. Every standard will come out with a 1 to 2 pager for clinicians, many of whom are in the room today, to talk about what does care look like. 12 to 15 simply worded statements. Every standard will have a 1-pager for patients and their families and their caregivers to say, this is what care can be and should be. Every standard will come out with an implementation plan, because all too often we know that good ideas and good evidence, and these will all be evidence-based, all too often there is not enough to help the system adopt what people want to adopt. People want to do the right things. They say, they see the truth. As a family doctor, I get material all the time, but we don't have the tools to help us adopt what we know we should, to change the practices in the way we want to. And so we will come up with a comprehensive implementation plan that will take all of our efforts. And of course, measurement is the cornerstone of improvement. If you don't know where you start, you don't know where you're going. You won't know if you're making progress. And so every standard will be accompanied by a data chart at the sub-LIN level to actually say, you know what, maybe you're already well ahead of the curve. Don't worry about this. You're doing great. But this area, you're 30% below. So you've got an opportunity to use the tools and the standards and the data, and we'll keep checking it over time. And so these will be our programs that we're launching. It's only going to work if we do a few things really, really well. The first is we have to have clinicians involved from the very, very beginning in all aspects in the design and the implementation of these standards. And we have, and we will. And similarly, it will only work if we have patients co-designing and thinking and involved from every step from beginning to end, including the topic selection, and we have, and we will. And it can only happen if we recognize that parts of Ontario are very, very different. The first clinical practice, or the first clinical practice I ever had an opportunity to do in med school in the first week was in Grimsby, Ontario. The first 1 month elective I ever had a chance to do was in Red Lake, Ontario. That summer of medical school, I went to the downtown Toronto Sunnybrook Hospital to do a trauma rotation. My career has gone from the inner city of Toronto to Red Lake and Kirkland Lake and Sioux Lookout and Iroquois Falls. The reality is the patients and the context of care is completely different, and the standards are not meant to paper over those differences. The standards are not meant to pretend that we are all the same as individuals or as patients, but they are intended to provide clear statements about wherever you are, what can care be, what is the opportunity, in a way that still absolutely allows for local context and local recognition of the variation that makes us who we are as people, and patient-centered care, the essence of what good care should be. So patient-centered care and a quality standards program are actually not opposites, but absolutely synergistic. It has to have transparency. People need to know and be involved in these standards. And again, it has to be comprehensive in its implementation. So today we're launching the first three. These first three will be out. I encourage and ask and hope all of you will drop by and at least look at them, pick up a copy of the patient one-pager, the clinician one-pager, give us your feedback, and we're going to be working on more. And these are just some of them. But today we're very, very proud to talk about this grand challenge of variation and what we think is an opportunity that only collectively we will succeed. And so I want to sort of head towards the end with this topic, or this idea of collectivity, which is this challenge of change. So I want to talk to you briefly and largely end with this concept of collective impact. It came out of the Harvard School of Business, and it is sort of the how of the grand challenges. If sort of the grand challenges is a visionary concept, the how we sort of get to those implementation of these grand challenges is embodied in this idea of collective impact. Came out of the Harvard School of Business, and first publication was actually a Stanford publication, as I recall, a few years ago. First of all, it talks about the need for a common agenda, and our grand challenge, our common agenda, is about these unbelievable variations. And again, I gave you a few examples, and if you think your part of the healthcare system doesn't have variation, let's have a coffee, we'll bring some data, and we'll show you some variation in whatever part of the healthcare system you're in. We need these mutually reinforcing systems, which will be this collective effort that we come together on, our measurement systems and the type of data we can provide increasingly at the provider level, at the sublin level, and this continuous communication. And communication is two ways. It's listening more than it's talking. And how do we get people together to say, listen, this is why opioids are so high in this region? And the answers are not going to rest in healthcare alone for these variations in many cases. It's also going to rest in education and in housing, in the fragility of food for many people, food scarcity. The true answers to these grand challenges will not rest just with the traditional understanding of healthcare and health, but in a much broader piece. And our communication, our engagement has to involve all of these people in our respective communities. So I'm going to actually end with an image that I am stealing from Trey Coffey. So I don't know if Trey's here. Trey gave a great speech yesterday about some phenomenal patient safety work that's being done at Sick Kids Hospital here in Toronto. And she opened with this slide. And this was her cover slide. And to be fair, it had her name on it, but I took it off. And I sort of loved the energy, and I love the poetry, and I love the element of risk. Because when we talk about a grand challenge, when we talk about committing ourselves to eliminating a critical barrier to better healthcare, when we talk about making a commitment to better, We're opening ourselves to change and to failure. We're opening ourselves up to new partnerships and new ways of working. We're opening up to new ways of thinking and to using new tools. And we're opening ourselves up to something that's really hard. And so there is energy and opportunity in the leap, but there is risk. But in coming here today, 2,500 strong, we are saying we want to take that risk. We believe in better. Better has no limit. Thank you.